My name is Stefano Molica. I am an honorary professor at Al York Medical School in UK, and I try to share some points concerning the management and probably the best choice of therapy in terms of BTKis for patients with CLL who are generally elderly and sometimes with a burden of comorbidities, particularly cardiovascular comorbidities. So I try to start this short presentation just to identify what are the mechanisms leading to the cardiovascular toxicity with the BTKis. Because I have to say that both first generation ibrutinib and second generation BTKis, such as acalabrutinib or zanubrutinib, they work binding covalently cis4 to cis481 in BTK. And a similar binding can occur also in other kinases, such as PI3K and ERB2 or 4, which play critical roles in the cardiovascular regulation. And these off-target effects may contribute to cardiovascular toxicity of BTKis that includes arrhythmia, hypertension, and bleeding. But the good news is that we are some second generation BTKis, such as acalabrutinib and zanubrutinib, and they have a lower cardiovascular toxicity. So in other words, they are able to induce lower cardiovascular complications. And this information mainly comes from the head-to-head trials comparing ibrutinib, the first generation, with acalabrutinib or zanubrutinib. So I am referring to the ELAVATE-RR trial, comparing in patients who are relapsed refractory the acalabrutinib versus ibrutinib, the Alpine, in which zanubrutinib was compared with ibrutinib. So, according to results of this study showing a lower cardiotoxicity with second generation, the American and European guidelines recommend second generation BTKis ibrutinib over, recommend second generation BTKis over ibrutinib. So, generally, acalabrutinib and zanubrutinib are indicated as the best BTKis in the first line and patient with relapsed refractory disease. However, also in these cases, the effect of BTKis are not completely eliminated. So this means that also when you prescribe to patient second generation BTKis, clinical monitoring for cardiovascular complication should be done. Importantly, from this study, we received information not only in differences between indifferences regarding the incidence of cardiovascular event, but also with second generation, we have seen that the time to the onset of cardiovascular event is longer than the time with first generation. For example, with acalabrutinib, the time to the onset of atrial fibrillation is approximately twice longer than what we see with ibrutinib. So this is an important observation because this observation provides a clue for defining the time in which the monitoring should be intensified. That could be different between ibrutinib and second generation BTKis. Another good news is that we have now non-covalent BTKis, originally designed to overcome the resistance related to the appearance of BTK mutation, but these agents have a safer cardiotoxic profile. And we have information, for instance, that when you move from covalent BTKis to non-covalent BTKis due to cardiac toxicity, more than 2/3 of patients, they do not experience recurrence of a cardiac event or new cardiac events. So we have also two important studies, two phase 3 studies of pirtobrutinib that will be presented at the upcoming ASH meeting this year. So I am speaking about the Bruin CLL 314 trial. It is a phase 3 trial comparing ibrutinib versus pirtobrutinib. So in this trial were included both treatment-naive and relapsed refractory CLL patients. Their median age is 6-7 years. And in this study, the incidence of atrial fibrillation was consistently lower with pirtobrutinib in comparison to ibrutinib. Mainly it was 2.4% with pirtobrutinib and 13% with ibrutinib. We have also another study that will be presented at the ASH meeting, is the Bruin CLL 313. This patient enrolled treatment-naive patient were randomized to receive pirtobrutinib versus BR. Also in this study, the rate of atrial fibrillation with the pirtobrutinib arm, it was 1.4%. Another option is that of using a fixed duration therapy in order to reduce the exposition time to the BTKis. And if we consider, for instance, the association of BTKi for venetoclax given for a fixed duration time, we have results of the AMPLIFY trial. The AMPLIFY trial assessed the role of acalabrutinib plus venetoclax, and the rate of atrial fibrillation in this study was really lower because it was less than 1%, and the hypertension, it was about 4%. So I have to consider that, however, that in the AMPLIFY trial, the patient population included CLL patients who were really younger, with a median age of 61 years, and they were medically fit. So we are waiting for a sub-analysis of patients older than 65 years, which accounts for about 27% of patients included in the AMPLIFY, and in order to see whether the results achieved in the younger population can apply also to the older patients and medically unfit. And there is also the CLL 17 trials. Results will be presented. The results at 3 years will be presented at the next ASH meeting. And in this trial, compare the fixed duration versus continuous therapy. And preliminary data suggest that the cardiac disorders with the fixed duration ibrutinib plus venetoclax were significantly lower than that observed with continuous ibrutinib. There is also a gap that require further investigation. It includes the impact of BTKi dose reduction on the development of or recurrence of cardiovascular events. We think that probably the future will give us important news with more mature data of non-covalent BTKi inhibitors, in particularly pirtobrutinib, and probably we will be able also to treat in a safe way also these high-risk patient with high-risk cardiovascular burden, and probably this patient will get some advantage from receiving pirtobrutinib or others non-covalent BTKis.